Have you ever wondered why some medications are meant to be swallowed while others dissolve under your tongue? It's not just about convenience or patient preference. It's because of the way the body processes drugs, and more specifically, how much of the drug actually reaches the bloodstream to produce its intended effect. A key factor is first-pass metabolism, sometimes called the first-pass effect. First-pass metabolism is a key physiological barrier, a critical gateway that a drug must pass through before it can reach the systemic circulation and begin producing its therapeutic effect. When a drug is swallowed, it travels to the stomach, where it dissolves. Once the stomach empties, the drug moves into the small intestine, the primary site in the gastrointestinal tract for drug absorption. To enter the bloodstream, the drug must cross from the intestinal lumen through a layer of epithelial cells lining the gut wall and then pass through the endothelial cells of nearby capillaries. If successful, the drug enters the blood in the mesenteric veins. But it's not in the systemic circulation just yet. Those mesenteric veins drain into the hepatic portal vein, which delivers the drug straight to the liver, the body's main site for drug metabolism. It's here that first-pass metabolism can significantly reduce the amount of active drug that ultimately reaches its site of action. Drug molecules that pass through the liver unchanged exit via the hepatic vein and travel to the heart through the inferior vena cava. From there, they enter the systemic circulation and are free to reach their molecular targets and produce their therapeutic effect. First-pass metabolism has some key characteristics. The term comes from the idea that a drug taken orally undergoes a first pass through the liver before reaching the systemic circulation. The liver is the main site of drug metabolism, which involves the actions of enzymes, as explained in my video on pharmacokinetics. Although the liver is the primary site, epithelial cells in the gut wall also contain metabolizing enzymes and can contribute to the first-pass effect. The extent of first-pass metabolism varies among different drugs and individuals, and is affected by conditions like genetics and disease status. The effect of first-pass metabolism is to reduce the bioavailability of a drug. That is an important pharmacokinetic term that I will return to shortly. Extensive first-pass metabolism can prevent some drugs from exerting an effect at all. An example is nitroglycerin, which I will return to later. At the very least, it means that higher doses need to be given or another route of administration used. In this way, the sensitivity of drugs to first-pass metabolism influences how we design drugs and formulate them. First-pass metabolism does not affect all drugs equally. Some are more prone to metabolism than others. The following properties make drugs more susceptible. Firstly, high lipophilicity. That is because lipid-soluble molecules are well absorbed and readily taken up by liver cells. Low solubility in water slows dissolution in the stomach, which delays absorption so that drug is exposed for longer to metabolizing enzymes in the gut. Drugs with a small to moderate molecular weight diffuse easily and are more likely to be substrates for liver enzymes. Some drugs have a higher affinity for metabolic enzymes like CYPs, especially those with aromatic rings, alkyl chains, or heterocyclic compounds. Drugs with greater susceptibility to hydrolysis or oxidation are more easily metabolized. For example, ester and amide bonds are easily cleaved by esterases or amidases, and the phase 1 metabolic CYP enzymes are oxidases that target easily oxidizable groups. So, what is bioavailability? It is a fraction of an administered dose that reaches the systemic circulation in its active form. It's expressed mathematically as the amount of drug reaching the systemic circulation divided by the total dose given. To determine a drug's bioavailability, it is typically administered to volunteers at the same dose, either orally or intravenously. Intravenous or IV administration delivers the entire dose directly into the bloodstream and is therefore considered 100% bioavailable. Following administration, blood samples are collected at various time intervals. The drug's plasma concentration in each sample is measured, and a concentration versus time graph is plotted. The area enclosed by the data points is calculated as the area under the curve. The black shading shows the area under the curve for the IV route and the red shading for the oral route. The area under these curves reflects the total drug exposure over time. By comparing the area under the curves from the oral and IV routes, the oral bioavailability can be calculated from the area under the curve oral divided by area under the curve IV. While looking in a mirror, stick out your tongue and roll it up to the roof of your mouth. Now observe the rich blood supply that runs underneath your tongue. You can see the lingual vein, which emerges from a dense network of capillaries near the surface of your tongue. The reason you can see the vein so clearly is that the mucous membrane, or epithelium under the tongue, is thin and translucent. This anatomy allows for rapid drug absorption directly into the bloodstream, known as sublingual absorption. Drug travels from the capillaries to the lingual vein, then to the jugular vein, vena cava, and heart, which pumps it around the body. This route takes the drug straight to the systemic circulation, avoiding the liver, GI tract, and first-pass metabolism. But if it's so good, why don't we use this route for all drugs? Because it also has limitations and disadvantages. The small surface area under the tongue limits how much can be absorbed at once, so only lipophilic drugs effective at a low dose will enter the circulation at a sufficient concentration to exert an effect. Drugs can have an unpleasant taste or cause irritation to the mucosa, reducing patient compliance. Absorption can be inconsistent and hard to control due to variations in saliva flow or patient behaviours that interfere with the process. Drug molecules can also be unstable in saliva. So, sublingual administration is used for lipophilic drugs, effective at low doses when a rapid action is needed. Examples include nitroglycerin, which rapidly alleviates angina, and buprenorphine to rapidly relieve pain and to treat opioid dependence. Additional routes of administration can avoid first-pass metabolism. Lipophilic drugs are absorbed into skin capillaries when given transdermally, for example in a skin patch. Drugs can be given by inhalation to target them to the lung. They can also be injected. You heard earlier that intravenous injection puts the drug straight into the bloodstream. Muscle has a rich supply of capillaries, so drug given by intramuscular injection can be rapidly absorbed. Subcutaneous injection introduces the drug into the fat layer below the skin. It is less vascularized than muscle, so drug is absorbed more slowly. For routine prescribing, oral formulations of drugs are usually preferred and can be achieved by designing the drug structure to have low affinity for liver enzymes. An alternative approach is to co-administer the drug with an inhibitor of the liver enzyme that metabolizes it. In our last approach, the first pass effect is exploited to create a drug that becomes active only after it has been absorbed. Patients are administered an inactive prodrug, which is metabolized to the active drug molecule as it passes through the liver. Enalapril is an example of a prodrug. It contains an ethyl ester group, which prevents it from binding to the enzyme ACE, short for angiotensin converting enzyme. In the liver, esterase enzymes hydrolyze the ester to a free carboxyl group. The newly created molecule is enalaprilat, which is an active inhibitor of ACE. Imagine a drug's journey as a wild roller coaster ride. It's swallowed, dives into the stomach, surfs through the intestine, and just when it thinks it's free, it's snatched by the liver for a biochemical makeover it never asked for. Some drugs make it through unchanged. Others don't survive the ride at all. So, what determines who makes it out alive? Let's summarise what is involved. First pass metabolism occurs primarily in the liver and intestinal wall after oral drug administration. It significantly reduces the bioavailability of many drugs, but the extent of metabolism depends on the drug's properties and route of administration. Drug design employs a range of strategies to overcome first-pass metabolism, including the use of alternative routes of administration, designing prodrugs, and co-administering enzyme inhibitors. Understanding this process is crucial for effective drug design, dosing, and delivery.